will start the second part of the symposium. After the symposium, we will hold a golf tournament and banquet today. For golf, the bus will take you to the golf course, Hawaii Prince Golf Club. It will take almost 1 hour. The bus will start at 10 a.m. from this hotel. So please gather at the lobby of this hotel at 9:50. We are sorry for limited time. And after golf, we will hold a banquet from 6:30 p.m. here. Now the symposium starts. I call upon Professor Kawamata and Professor Sonoda. Please start the session, malignant tumor.
Good morning, ladies and gentlemen. We'll start plenary session 3 on malignant tumor. I am Professor Sonoda. I will share 4 or 3 papers. So the first speaker is Professor Toshihiko Wakabayashi. The title of the paper is Diagnostic Performance and Safety of Positron Emission Tomography in Patients with Clinically Suspected High and Low-grade glioma. Please.
Good morning, ladies and gentlemen. First of all, thank you very much for giving me a chance to talk in this special conference. And I really appreciate for the President Kinouchi and President Watanabe for giving me a chance to like a good chance. And now I focus on the diagnostic performance and safety of PET probes, which was newly developed in recent few years, and no conflict of interest. And so, as you know, the malignant glioma is still fatal disease, and now a lot of neuroscientists now focus on to develop and improve the diagnosis and treatment methodology for such kind of malignant tumors. And now we focus on the 3 keywords to develop such kind of program for malignant tumor, like molecular imaging probe, or highly qualified laboratories, and molecular technology therapies. And recently, in the neuro-oncology, focus on the diagnosis of malignant tumors, like PET imaging in glioma, for example. And now we are now discussing about diagnosis by PET. And today we now focus on the newly developed new probe by the support of metaphysics in Japan, like made fluorocyclovins named FACBC from now on, as known natural amino acids, and then entering by the acid transporter to the cells and non-metabolized new types of probes. And yesterday also some presenter mentions usefulness of diagnosis of glioma using by mentioning PET. And compared to this probes, this FACBC now has a long half-life, like more than 110 minutes. And also because of the non-acid probes, the background is very low compared to the methionine. And also it was low accumulation in normal brain, so non-response to the inflammation areas. And this is illustrative photo of compared to the methionines. Also, both of the FACBC and methionines was accumulated in the tumor of glioblastomas, as you shown in this slide. But because of the low backgrounds of FACBC, now sharply focus on the mass of probe compared to the methionine. And now we are going to the phase 1 and phase 2 study already. And the PET brevis as FSCBC was usefulness for the diagnosis of gliomas compared to another PET it was developed before. And also compared to the enhanced area of T1 weighted image MRI, showing the sharply enhanced mass of the malignant areas. Now we are moving to the phase 2 trial with the help of 11 institutions in Japan, and already it was accumulated and discussed with company of Japan, and already biopsy was done with newly diagnosis of this probate compared to MRI enhanced areas. And this is a summary of characteristics of patient with the support of institution. 42 patients was accumulated and already diagnosis was done, and finally 35 patients was analyzed with this report. And during the diagnosis and the operation time, we ran samples with several parts of gliomas or tumors. And as this slide shows, this is 3 parts was separated. One part is positive of FSCBC without no enhancement area. Both was positive of PET probe and MRI image, and both of negative image of MRI near FSCBC. As you can see in this slide, both the positive areas is very also high ratio of finding the glioma, but as the first line shows, even in the negative of a T1 weighted image, with positive FSCBC was found 100% of malignant tumors in the sampling. And this is one of the illustrative cases, as it shows. Left posterior areas were enhanced with regularly, and the typical MRI showing of glioblastomas. As the lower line shows the FSCBC PET, and you can see its image covered over more than the MRI image, enhanced image. And this is anaplastic astrocytoma case. The big tumor was found in the intra-area of left side, but only a small part, the major part of these areas was found on positive area of FSCBC. And we sampling with these hot areas and showing the grade 3 gliomas, but another area is a low grade, like a grade 2 and 1. And this is showing the accumulated pointing of areas of highly malignant areas. And compared to the methylene beta, as the left shows, is low because of the low accumulation of background of normal brain, sharply finds accumulation all over PET. And this is a comparison of methionine PET and FSCBC image. And the pattern is almost same as methionines, but because of the background and also non-amino acid areas, the sharply finds area of hot areas. And this already is summarized and published in the paper, and showing the good result of this multi-center phase 3-2B trials. And as you know now, this FSCBC will be a nice probe of PET, and going on now as a phase 3 studies. Now summarize papers, and now we're discussing the PMDA to make new drugs of PET probes. And finally, the collaborator of this phase 2 studies. And thank you very much for your information. Thank you.
Is there any comment, question, or things? Is this less correlated with tumor grade, not the extent of the tumor location?
Also, the extent of tumors is very enhanced compared to the MRI imagings, and also the accumulation ratio is compared to the grade is well related, I think.
Next paper. Presenter is Dr. Hiroka Sarahiro. The title of the paper is How to Perform the Biopsy for Gliomatosis Therapy.
Good morning, ladies and gentlemen. I'm glad to present our work this excellent conference. Today, I'll talk about gliomatosis therapy. It seems to be. I'm very sorry for my PC. I can present it without swearing.
Okay, we will change the speaker. The speaker is Yuki Shiraishi from American University. The title of the paper is Force Positive Inflammatory Change Mimicking Glioblastoma for Deformity Using 5-ALA Guided Surgery. Please.
I'm a journalist in a medical university hospital. I work as a neurological senior resident from April this year. Nice to meet you. I would like to talk about post-positive inflammatory change mimicking glioblastoma multiforme under 5-aminolevulinic acid-guided surgery. This is a case report. First, I will give you the introduction. 5-ALA guided surgery is one of the gold standard perioperative modality for maximum resection of malignant glioma. However, 5-ALA in process does not always indicate the presence of malignant tumor cells. So, 5-ALA positive and malignant tumor cell don't mean the same thing. In the next slide, I will show you case presentation. This patient is 44 years old woman with no previous history and family history. She presented with headache and visual disturbance. She had a neurological deficit. Her vital was normal. CT shows the abnormal lesion in the left occipital lobe with perifocal edema and hemorrhage. MRI showed acute phase of intercellular hemorrhage in T1 weighted image and perifocal edema in T2 weighted image. Diffuse weighted image indicates the lesion can be defined as a brain abscess. Contrast MRI showed a heterogeneous contrast effect. In a site except approved intercellular hemorrhage of T1 weighted image. Chest and abdominal CT had no systemic cancer. Our preoperative diagnosis was malignant glioma. In the next slide, I will show you perioperative image. After the occipital corticotomy, 5-ALA in process demonstrated the positive reaction in the surface of the lesion. Before resection, we diagnosed the malignant glioma, but intraoperative frozen section revealed only inflammatory change and no malignant tumor cells. Eventually, we performed the lesionectomy without the removal of surrounding gliosis. Our perioperative diagnosis is no malignant cells. In the next slide, I will show you pathological findings. HE stain showed of no malignant glioma cells and invasion of lymphocytes. Moreover, we checked the stain of specified pathogen, but we could not demonstrate the proof of infection by specified pathogen. So, gram stain and path stain, Crocott stain, geomycin stain are negatives. In this slide, I will show you clinical course after surgery. This patient had no neurological deficit. Follow-up MRI at 3 months showed no recurrence and an unchanged post-operative cavity. the next slide, I will show you the discussion. This is the metabolic pathway of 5-ALA. Exogenous 5-ALA is transferred into intercellular by PEPT1 and metabolized by several enzymes. Exposure to blue light leads to the excitation of the protoporphyrin 9, and we can see red process. In this slide, I will show you the immunohistochemistry. We confirm the presence of macrophage with positive stain by IHC in CD68 and increases expression of PEPT1 and suppresses expression of ABCG2 and ferrokeratase. So the increases expression of PEPT1 and suppresses expression ABCG2 and ferrokeratase, thereby increasing the intercellular accumulation of protoporphyrin 9. So we can see red influxes. In this slide, I will show you the preview reports. Several reports about false positive lesion were published in the brain abscess and capsularized hematoma by caverous angioma. I'd like to finish by summarizing the main finding of this study. We report a rare case of 5-ALA-induced influxes with IHC caused by inflammatory change after an unknown infection. False positive can occur with accumulation of protoporphyrin 9, and it is important to use caution with 5-ALA guided surgery or tumor resection. Thank you for your attention.
Is there any comment or question, please?
Thank you for your presentation. My name is Norito Fukuda from Yamanashi University. I have one question. 5-ALA positive region and highly enhanced region on MRI is was the same region.
Same region. So 5-ALA same region.
5-ALA and highly enhanced on MRI.
So 5-ALA evaluation.
Professor Nakase, parallel is put in diffusely, so maybe involved in the region. Yes.
Okay, thank you very much. We will move to the next speaker. The next speaker is Hirokazu Arahiro.
Ladies and gentlemen, I'm very sorry for my PC, and I would not like to disturb your golf, so I should rush. about glutamate surgery is to be a little bit out of date. However, we believe this concept is very important. Background: glutamate surgery. This is known as a glial tumor spreading over 3 lobes. The diagnosis GC disappeared from WHO classification in 2016. However, glutamate surgery is different from other low-grade glioma. More than half are IDH wild, and we can't reject totally because of the wide spreading. So we always wonder where and how the biopsy should be performed. So this purpose of this study is we retrospectively reviewed how to decide where to biopsy for GC and discuss these pathological findings. Methods. From 2002 to 2017, we corrected diagnosed patient with GC. And GC is defined as a glial tumor spreading over 3 lobes or more. We corrected 10 patients, and 7 were female and 3 were male. And the mean age was 45 years old, and the mean overall survival was approximately 33 months. We performed open biopsy for 5 patients, and the stereotactic biopsy for 4 patients, and 1 is endoscopic biopsy. Of course, all biopsies were performed from non-eloquent area, and the biopsy was based on tissue-weighted image. Hyper-area was 5 cases, and MRI enhanced or PET accumulation area also 5 cases. There is no biopsy failure and no complication. WHO grade, 8 patients were 2, and 2 patients were 3. IDH1 mutation was confirmed in 3 cases. According to WHO classification 2016, the diagnosis as below. I'll show you in detail after that. This table shows the characteristics of 10 patients. Almost patients were treated with chemo and radiotherapy, and only 1 patient was treated only temozolomide because of his high age. And this table shows where to biopsy, and 5 patients were based on tissue-weighted image hyper-area, and 5 patients were based on MRI enhanced. This is a very old case. We didn't perform the PET study. But recently we performed the PET, and 5 cases are MRI enhanced or PET accumulation area. If we performed the biopsy was performed MRI enhanced or PET accumulation area, it shows a high V1 index, and 2 cases showed grade 3 glioma. However, this did not correlate with overall survival. We checked AC, not only AT, but also IDH1 or other immunohistochemistry. We confirmed 3 cases IDH1 mutation, and unfortunately, MGMT IC didn't correlate with IDH1 mutation, and also didn't correlate with overall survival. 1 case, oligodendroglioma grade 2 shows 1p90q co-deletion. However, this 1 case, anaplastic oligodendroglioma didn't have IDH1 co-deletion. 1p90q co-deletion. I'll show you 1 case. This is a 66 years old female who had a weekly epilepsy, and this is the enhanced area, also PET accumulation area. We performed biopsy from this enhanced area. Interpretatory, we performed ECO-Z, and fortunately, this enhanced area is the same as epileptogenic area. So after gyratomy, we confirmed ECO-Z again, and a little bit spike left, and additional section, and spike was gone. This is a postoperative MRI. and her epilepsy also was gone. Summary. All cases, biopsy was successful and no complication happened. A biopsy from MRI enhanced area or beta accumulation area yielded pathological findings of high grade and high B1 index. However, it was not involved in overall survival. In case 9, open biopsy was performed as an epileptic surgery. I'll show you one paper from Germany. They made a heat map from about DNA maturation with 25 glioma cerebral patient and other more than 100 other glioma patient. This black means the glioma cerebral patient. As you know, other glioma has a various kind of phenotype, normal brain, mesenchymal, tyrosine kinase, or some IDH1 mutation, and also glioma cerebri has a various type of epigenetics and genetics feature. So glioma cerebri doesn't have a tendency of this genetic feature. So they inferred why glioma cerebri disappeared from WHO classification in 2016. They also inferred this is the overall survival Kaplan-Meier curve. WHO grade didn't correlate with overall survival. The MT mutation did this overall survival. So they also inferred pathological grading is not so important and the other biomarker more important. Conclusion, MRI enhanced and PET accumulation location yielded high grade and high B1 index. However, this high B1 index was not involved in overall survival. Biopsy should be performed, of course, non-eloquent area to reveal not only pathology but also various biomarkers. Sometimes biopsy should be done as epileptic surgery. Thank you very much for your attention.
Thank you very much. The time is limited, so unfortunately, so we will move to the next paper.
The next speaker is Dr. Kawataki from Yamanashi University. The title of this talk, the new operation system in integrating multimodal information for glioma surgery. Let's start.
Thank you, Chairman. I would like to talk about our operation system for glioma surgery based on 3 Tesla IMRI. The goal of glioma surgery is to achieve the maximum tumor resection and preserve the neurological function. So surgeons need easily to recognize multimodal information during surgery. Intraoperative MRI can provide updated neuroanatomical information. We developed a new surgical method based on this IMR system and its application in glioma surgery. This is our IMRI system, 3 Tesla high-field magnetic. After draping the patient, MRI can be moved from the next room without any moving the patient. To achieve maximum resection and functional preservation, we use this IMRI system. However, we have to recognize too many information, such as anatomical and functional information. Actually, it is very tough work to get accurate decision making for surgeons. So we devised some tips which surgeon can easily recognize them in our new operation room. We arranged 4 full HD monitors which can display maximally 4-channel display output like this. And this monitor setting makes it possible to show much information and easily provide them to the surgeons. Patients and method, 19 consecutive glioma surgical cases, analysis points are extent of resection, surgical complication, and MMD 3 months after surgery. I will show 2 representative cases. First, diffuse astrocytoma, 26-year-old female, left frontal diffuse astrocytoma. Seizure onset, no neurological findings on admission. High-intensity lesion was observed on left frontal lobe without enhancement. And broca and pyramidal tract were very close to the lesion. We have taken the tumor resection and confirmed the residual tumor. Here it is. And we continue to resect it additionally and achieved complete removal to keep the TTI tract. Next case is a 37-year-old female. She had suffered progressive motor weakness. On admission, she had moderate right hemiparesis. MRI revealed a ring-like enhancement area mainly located in the premotor cortex. Primary cortex is adjacent to the lesion. So left frontal craniotomy was performed and monitor setting. The dissection the tumor surface, and we carefully resect the posterior side of the tumor. Here is a premotor sulcus, so it's very close to the pyramidal tract. We use white matter MEP. The IMRI revealed residual tumor with the posterior side of the cavity, so continue to the tumor resection based on the updated neural navigation. And using white matter MEP, some milliampere is a limitation of dissection. This is binary view, and left is the adenosine welfare. I show the residual tumor just posterior side here, and post-operative MRI shows a complete removal of the enhancement area, and the pyramidal tract remained after MRI. Now undergoing the radiotherapy, her KPS 90% with slight disturbance of the finger movement. IMRI was performed on average 1.6 times, additional removal in 16 patients among 19 cases. Extent resection increasing 83% to 96%, with no complication depend on IMRI. Operative mobility was observed, motor weakness deterioration in 3 cases. Discussion. Our MRI is a high magnetic field which can provide not only higher tissue contrast, but flare and village and DTI tract. And intraoperative updated navigation can correct brain shift and demonstrate residual tumor. And to recognize the resection layer on real time, pointer probe chip as navigation pointer is very useful. In this system, we devised display setting to provide multimodal information for surgeons. And this monitor can place the optimal position of operator, and it's possible to recognize the information. So synchronized recording has benefit retrospective analysis of operative problem and pathological study linked to the positional information of MRI. In conclusion, intraoperative 3-Tesla MRI operating room system integrated multimodal information contributes to perform the safe and durable glioma surgery. Thank you.
Thank you for your presentation. Just a question from me. I'm very curious to see how long does it take to make the intraoperatively updated tractography images? How long does it take additionally?
How long the time?
Yeah.
Okay. Mean time is 58 minutes imaging per times.
I mean the time to make the intraoperatively updated tractography.
Tractography.
Yeah.
Tractography is possible to make the during imaging, so it's not consume the time.
Okay, thank you. We move on to the next the speaker, Dr. Sonoda from Yamagata University. The title of the talk is Opening the Ventricle During Surgery Diminishes Survival Among Patients with Newly Diagnosed glioblastoma treated with carmustine wafers. Please start.
Thank you, Chairman. Now I'm talking about the opening ventricle during surgery is associated with survival among patients with newly diagnosed glioblastoma treated with carmustine wafers. There is no conflict of interest. Carmustine wafers were approved in Japan for newly diagnosed and recurrent malignant glioma during 2013. Carmustine containing 7.7 mg of BCLU are designed to slowly release carmustine over a few weeks after being placed in the resection cavity. The ventricle is often during surgery like this to achieve maximal resection. Carmustine wafers implantation was not recommended in such situations, but particularly in Japan, we often put on the wafers after occluding an open ventricle using gel form and collagen sheet like this. However, whether sheet of carmustine wafers implantation actually confers a survival benefit for patients who undergo surgery with an open ventricle to treat glioblastoma remains unclear. So, we collected clinical imaging and survival data from these centers and performed a retrospective study of 122 consecutive patients with newly diagnosed glioblastoma to determine adverse events and efficacy. This slide shows a profile of the patients and tumor characteristics. Among 122 patients, 72 are male. Mean age was 66 years. Gross total resection was achieved in 57% of the patients, and the ventricle was opened in 47% of the patients during surgery. A mean of 6.45 carmustine wafers were implanted. Overall, 54 adverse events of all grades occurred in 35 patients, and the most common adverse event was new seizure, aseptic meningitis in all 4 patients with opening the ventricle during tumor resection. However, Other adverse events do not significantly differ between the patients who underwent surgery with an open or closed ventricle. Among 83 patients with recurrent disease during follow-up, 64% had local recurrence. The nature of the recurrence did not significantly differ between patients with an open and closed ventricle during surgery. The median follow-up was 16.1 months, and 55 patients died during the study. The 1 and 2 year overall survival rate was 79.8% and 39.5%. Progression-free survival was 10 months, and median overall survival was 21.7 months. As shown in this slide, median progression-free survival was 99.1 in non-gross total reduction patients. In gross total reduction patients, median PFS was 10.9 months. There was no significant. Regarding to overall survival, 22.3 months in GTR patients and 90.7 months in non-GTR patients. Overall survival did not differ according to the extent of tumor reduction. However, the median PFS was 7 months in open ventricle. In closed ventricle patients, median PFS was 10.9 months, 12.8 months. Similarly, median OS was 18.6 months in open ventricle patients, 26.9 months in closed ventricle patients. Both PFS and OS were significantly longer for patients with a closed rather than open ventricle during surgery. The progression was significantly worse for patients with an occluded surgical ventricular opening before calcium wafers implantation than for those without ventricular opening. Now we speculate two possibilities. The first, the prognosis was worse for patients when the glioblastoma was closely associated with subventricular zone SVZ than those without SVZ. Access through an opening ventricle during surgery tended to require more frequently for SVZ positive glioblastoma. Second, calcium wafers implantation was not effective for patients with ventricular opening. Calcium released from a wafer might leak into an opening ventricle that was sealed by collagen-free or gelatin sponge. 4 patients with ventricular opening in the present study developed aseptic meningitis. In conclusion, median progression and median overall survival was 10 and 21.7 months among patients with newly diagnosed glioblastoma, treated with a maximum self-resection, calcium wafers implantation followed by radiotherapy and concomitant temozolomide. A multi-center random study is essential to validate its survival and toxic data. However, patients with ventricular entry during surgery might be excluded from future investigation. Thank you for attention.
Thank you for your presentation. Are there some comments or questions from our audience? So there are no differences on adverse effects between the with or without opening the ventricle. Do you need some special technique to prevent the adverse effect besides the regular technique?
No, routinely don't have calcium wafers.
Okay, thank you very much for your presentation, and we'll try to close this preliminary session. Thank you for your cooperation.
Now, special lecture 4 will be started by the president of Professor and Director of Nobuhito Saito Tokyo Universities. And he is presenting today the title of Treatment Strategy and Genetic Analysis of Hemangioblastoma. Professor, please start your lecture.
Thank you, Professor Wakabayashi. Today's my talk is about hemangioblastoma, including VHL disease. So hemangioblastoma is, as you know, benign neoplasms, WHO grade 1, and histologically, stromal cells are considered to be neoplastic, and it has many vasculatures in it. And almost 24 to 25% is considered to be VHL related. And from the window of VHL disease, literal angioma or hemangioblastoma in cerebellum or medulla, or pheochromocytoma, pancreas cyst, and renal cell carcinomas are well known. And the causative gene is a VHL, which is located in 3p25. So to treat these VHL patients, we have set up a special team, a special VHL outpatient clinic. And through this clinic, we use research, genetic analysis, and also clinical genetics, genetic counseling. And we communicate with a VHL patient society and also cycle treatment or gamma knife scheduled. And this is our recent paper published in Neuro-Oncology. Dr. Takayanagi has done this genetic analysis. As you know, Anuson 2-hit cell with VHL disease, it's simple. So in germline, they have a VHL mutation here. It's a red star here. And the large deletion occurs, and it becomes two hit and become neoplastic. The non-herited tumors, in some point, one hit is mutated somewhere, and then two hit becomes. And if it's so, the story is quite simple, but it's not. It's not. And this is the previous report from Glasgow. And left side VHL disease, and right side is sporadic. And VHL mutation is seen in 97% of VHL disease. It's quite high. But VHL 2-hit biallelic inactivation was seen only in 62%. And we don't know what's going on. And in sporadic cases, that's much worse. We could find a VHL mutation in 23% only, and 2-hit only 10%. And why this is so low? And to increase to find out the VHL mutation, we have done research. This is another one. This is clear cell renal cell carcinoma study, and almost they checked 100 sporadic clear cell carcinoma, clear cell renal carcinomas, and they found LOH and VHL mutation in very high percentages. So brain VHL disease is a little different. In renal clear cell carcinoma, the VHL mutation is very high. So what's the difference? The objective is to evaluate the contribution of VHL alteration or inactivation to hemangioblastoma tumorigenesis. And we used multiple analytical genetic techniques to comparatively analyze VHL-related and sporadic hemangioblastomas. And materials 7 VHL patients, 11 samples, and 21 sporadic patients, 21 samples. Almost no difference, but the VHL patients are a little younger at 31 average, and compared to 48 to sporadic. And the method is to find out the VHL mutation, we did direct sequence and also MLPA and target deep sequencing. These are pretty important. And chromosome 3 LOH to find out chromosome 3 LOH SNP array was used. And VHL promoter methylation was a methylation specific PCR and bisulfite sequencing. So this is the example of VHL mutation. So here, like this missense mutation was seen. So in hemangioblastoma, the tumor is tumor cell, but it's always contaminated with a normal vasculature. So like this, it's not simple change, but two codon, chimine or cytosine is detected here. And this one is MLPA, you can see the division here. And also direct sequence detected only 4 sporadic hemangioblastomas. So among 21, only 4 VHL mutation. But we did targeted deep sequencing of VHL, and 9 of these 70, 21 4 is 17, so these 17 was deeply sequenced, and we could find out 9 mutations. And these are the result on the sporadic cases. We could find out these mutations. These are all previously reported ones, so no new one. But we can find out this kind of mutation. And this is SNP allele, and we can find out example 1, loss of chromosome 3 here, and loss of chromosome 6 and 10, these. And also copy number neutral LOH of chromosome 3. Here it's deleted, but here it's double, so copy number is neutral. And this kind of change can be found using the SNP allele. And also VHL promoter methylation here. This is PCR sample, and you can find out the methylated PCR here, so it's positive. And also this is promoter bisulfite methylated and unmethylated detection. Sorry for this busy slide, but we could find that VHL mutation here like this on VHL diseases in every case. So by adding deep sequencing, it's more effective. And we also find out LOH in these cases. But interestingly, VHL methylation was not found in VHL diseases, not in sporadic, but in VHL. And by allelic inhibition was found like this. And in sporadic cases, we could find out the mutations and the LOH, and also we can find out the methylation here like this. This is completely different from the VHL cases, and to hit here. So this is a summary of our findings, and we could find out VHL mutation in 100% of VHL diseases. and 2 hit 64%. This is not so different from the previous reports, but here in sporadic cases, VHL mutation was found in 62%, and promoter mutation is 33%, and also VHL2 hit 52%, and we call VHL1 hit any kind of a VHL anomaly was found in 95%. So maybe we have something else which was not detected yet. So that's worthwhile investigating. But in the present form, we can find out at least 1 hit in sporadic cases. So this panel is VHL cases, and this is sporadic cases. As I have shown before, here is a VHL methylation, this line, and chromosome 6, not 3, chromosome 6 LOH here, and chromosome 10, sorry, LOH here. And in VHL disease, we didn't find out any of these patterns. But in sporadic cases, we could find out these abnormalities. So this may tell something. So it is worthwhile investigating. And as I have mentioned, why could we detect VHL alterations in 9 additional sporadic hemangioblastomas by targeted deep sequencing? That is because VHF was contaminated with normal vasculature, normal vascular cells. So by deeply sequencing, we can read each of the cells. We can read stromal cells and also vasculatures. So we can find out more precisely the status of the mutation. So in conclusion of genetic analysis, with advanced technologies such as next generation sequencing, SNP-array, MLPA analysis, and bisulfite sequencing, we identified increased number of hemangioblastomas with genetic and epigenetic inactivation of VHL than previously reported. In addition, the data suggested that other unknown mechanisms may also be involved in the pathogenesis of sporadic hemangioblastomas. So this is our research. And about surgery, hemangioblastoma, cystic cerebral hemangioblastoma is not so difficult, but I'd like to show 2 difficult cases. One is medulla, and sometimes we may need pacing, like a seal or into a heart pacemaker. And to approach this brainstem, we use a cerebral medullary fissure approach. I mean, we can widely open this tonsillar space laterally and medially. And hemangioblastoma is something between the cavernous malformation and the AVM. It has more vasculature than cavernous malformation, but less than AVM. So we can find that almost all feeders and drainers, we can identify almost all feeders and drainers before surgery, and that is pretty advantage for us. And this one is a medulla, small hemangioblastoma, and because it's small, it's quite simple. The removal is quite simple. And this one is not associated with a cyst, but the surrounding medulla was edematous, and it's by cutting this pia mater, it's safely removed. So, and the drainers at last. And just dissect from the middle. And this one is not so complicated. And this one is a 14-year-old male, boy, and he suffered from progressive weight loss from 40 kilogram to 28 kilogram. And the hemangioblastoma was located in the middle. But it's, as I said, feeders and drainers can be identified before surgery, so we can just clip these feeders at first, and it usually have a cyst, surrounding cyst, not in every part, but in some parts we can utilize cysts. So by utilizing these cysts, we can connect the dissection plane from the middle. And again, the drainer lastly. And this boy quite well recovered, and in 2 months, the body weight became normal. And another case, as you can see, this patient has cystic lesion surrounding, and we can identify the feeders and drainers here. And by occluding feeders first, we can safely remove this tumor. So, quite similar image here as before. And we identified 3 main feeders here, and cut and clipped with hook clip. And post-op. And this one was a difficult case, not good surgery. A 51-year-old male and headache and anesthesia for 3 months. And he referred to us, but emergency surgery was done due to acute intracranial hypertension syndrome. And as you can see, this one is deeply located in the cerebellum. And I think this type of tumor is, in any case, very difficult. Normal brain or cerebellum structure here on the surface, and in the deeply seated place, high vasculature tumor is located. And this kind of tumor is pretty difficult. And we took suboccipital approach, and because of that, I had a very hard time here. And first, we identified midline, and maybe I should skip here. Okay, so patient's head here and curled out and this is tentorium. And I just retracted this cerebellum and tentorium, but it starts bleeding, and this bleeding never stopped. So I couldn't use the left hand is just sucking the bleeding. So this tumor is attached on the cerebral tent, and by in this case we haven't used the 3D simulation method yet, so it was quite insufficient, the surgical simulation. And I can't stop here, so I have to remove the tumor as early as possible, and it's, the cerebellum is bulging here. As you know, the blood is behind the cerebellum. So, but I needed to but in this case, feeder coagulation is not so effective. You know, we need it to remove as quickly as possible the tumor. So, sorry, maybe this the field is confusing, so I could here. And gamma knife lastly. Gamma knife is also effective. And in University of Tokyo, we had 97 hemangioblastomas from 21 patients, and sporadic 7 lesions, BHL related 90 lesions, and for a period 96 months. The location cerebrum, brainstem, and temporal, like this. And median target volume is 0.13, and median marginal dose 18 million. And this is actually tumor control rate. And in 5 years, 94%, 10 years, 80%. It's not so bad. It's okay. And especially, this is factors associated with good tumor control. Solid lesions, solid tumors are effective, and tumor volume small is effective, and BHL-related lesions are effective. So if you find small, multiple BHL lesion, then gamma knife is pretty effective. So this is an example. You can see multiple tumors and small, and it's not possible to remove all of these small tumors by surgery. So, but the gamma knife is effective in this case. And by literature review, largely the median target size was small, and tumor control rate was 70 to 80% at 10 years, and the complication rate was 0.023%, and quite the same. And like this, BHL is more effective than sporadic cases. So if you find multiple BHL cases, you may consider gamma knife. And this is solid, cystic, and BHL, and sporadic. Anyway, a solid mass is also effective. And adverse events, 38 lesions in 13 cases, and lenema-8, tumor enhancing lesion 9, enlarging cysts 5, and neurological deficits in 4 cases. This is an example of what we do here. So this is the last slide. I presented VHL genetic analysis and surgical treatment of hemangioblastoma and gamma knife. So thank you very much for your attention.
Thank you very much, Professor Saito, for the nice presentation about the molecular windows and coding with the genetic analysis and operative strategy, and finally the gamma knife effectiveness. The time is scheduled, but are there any questions? Please.
Thank you very much for a nice presentation and latest to your research. And you showed us difference between disease-related and sporadic one. And the maturation is positive and sporadic. Is there any phenotypically the difference in the disease for the vasculature system or something like that? And also, is there any supposed factors of the epigenetic factors for the sporadic ones?
Yes, one legend is that we did this genetic analysis on tumors in sporadic cases. In VHL cases, we can do the genetic analysis, but ethically, we have not gotten the permission on sporadic cases yet. So
I see. Thank you. And you showed us a beautiful surgery and also the very difficult ones. And do you try to do embolization before surgery in some cases?
I have not yet, but in some cases it may be necessary. But when I was young, our supervisor once tried the embolization, but by that the tumor swelled and we had hard time, so we are not so positive on the pre-embolization, but in some cases probably it is effective.
Thank you very much.
Okay, please.
Thank you for a good presentation. My name is Dr. Senbokia from University of Yamanashi. I have one question. How much time does it take to get targeted deep consequence compared with blue-chip sequence?
Sorry, I have not done myself, so I have to ask my colleague. But how much?
How much time?
Time is maybe 1 week or something like that, but it costs a lot. So we need to buy.
Okay, please. The last.
So, T. Matheson, I have a question and a comment. I'll start with a comment regarding embolization because we have operated some of these cases. Also, we have had very good help of embolization, especially for the nasty case you showed with continuous bleeding. We had a case like that and we were a bit afraid of doing the surgery and had it embolized. So. But there is a problem with embolization of these lesions, and it is that the vessels that need to be embolized frequently have collateral flow to the cranial nerves. So with embolization of these lesions, we do run risk of getting facial palsy and lower cranial nerve damage. But my question is, with von Hippel-Lindau cases, you had one of the gamma knife patients had a temporal lobe lesion, which is not typical for von Hippel-Lindau. We had a case like that. We had followed for long and finally operated, and we removed 3 vascular tumors. To our big surprise, 2 of those were metastases from renal cancer. Have you come across patients or situations like that? Or how do you work up the patients to detect the ones who may have
sorry, I don't have further information right now, so maybe later.
Okay, now time is up, so now it's closing this special lecture. Thank you very much.
I'd like to announce the golf tournament again. The bus will take you to the golf course, and the bus will start at 10 a.m. from this hotel. So please gather at the lobby of this hotel 9:50. Please prepare for that. Thank you very much.
Okay, we would like to start Symposium 5 Ischemia. I'm Joe Nakagawa from Osaka, the chair, and co-chairman is Kazuya Kanemaru from University of Yamanashi. In this symposium, we have excellent 5 papers. So I will introduce first and second paper. So let me introduce our first speaker, Dr. Hiroyuki Toyama. His paper is entitled, "To what extent can embryonic following setting be predicted? Drug diagnosis with rather clinical." Could you start your lecture? Great.
Thank you very much for my introduction. First, I will explain about radar. Radar is one of the MRI sequence, radar aggregation radar. Nowadays, cardiac stenting with general tourism method to cardiac arteriosclerosis, especially after 2008, we can do this method using insurance. So number of cardiac stenting is increasing in Japan, as well as our hospital is doing it too. Cardiac stenting is less invasive than the open surgery, but as you already know, there are two main complications post-stent, bleeding and embolism. So we need to select the best treatment method, which is stent medicine, endoarterectomy, or cardiac stenting. Furthermore, the most common complication is post-stent embolism. So we need to make a more detailed drug imaging to prevent this embolism. We usually use ultrasound echo, MRI, 3D CT, and DSA. Sorry. Recently, blood clot method has become widely available to know the unstable plaque. There are some kind of methods in MRI as shown in the slide. I think these two methods are well known. Prototype of blood method can get sharp image because it is ECG synchronized. But blood contrast is always down because TR is decided with heart rate. When TR is set, blood contrast decreases. Also, MPLH method is a special method that combines fat suppression with infarction recovery. So it can do the blood suppression, and this method is able to do multiplannar recontraction. However, it cannot be used to decide the determinant company because of patent. Therefore, it's difficult to make it as a standardization. However, these conventional methods are difficult to define contrast inside the drive. I think ideal MRI track images, no ECG, no TR extension, and fine contrast inside the plaque, and it's able to distinguish a lipid plaque, bleeding plaque, or fibrous plaque, because these factors decide the surgical result. I will explain about radar method. Radar method is actually one of the black box methods, but it's easy to distinguish a lipid plaque or bleeding plaque. Radar method can get sharp image using motion artifact suppression. And later uses self-navigation system without ECG synchronized because it can make flattened blood suppression image with a TR extension. It's called radar, radial excision regime. It made by Hitachi Medical Company. Furthermore, it's able to change the contrast parameter and do color mapping and grade it in 3 categories. Green is curvation or fibrous. Yellow is livid. Red is bleeding. It's easy to understand the situation inside the plaque. This is method subject. We studied the method from October 2014. 120 cases were performed corresponding at our hospital. Out of all of 23 cases, post-operative diffusion rated high are subjects. I will explain about typical case. Severe stenosis over 90%. I thought this infection was A2A embolism with blood rupture. The blood image, blood fat is high. Later was red, low echo, step primary bleeding. In this case, commonly you might do endotheliectomy, but he had a hypermanic death, so we could not do the general anesthesia. So we performed the cardiac stenting with flow reversal system. Case video. Severe stenosis after 3 months. With moment during flow reversal system, we pass through the guide wire into the plaque, and we use spider. And for dilatation, we left wall stand and posterior dilatation. Pardon me. Final view. There are nothing embolism, good result. I will show you the result. Out of 120 cases, there are 23 cases that had high figurant acid area at the diffusion rate is high. There are simple results. 2014, 2015, 2016, and 2017. Out of 23 cases of diffusion rated high, 22 cases were bleeding inside the plaque using the bladder. It was over 90%. And furthermore, we were analyzing with multi-algorithm. We are doing logistic analysis. In conclusion, radar is one of the useful inspections to predict the post-tending error. However, we need to correct and analyze the other risk patterns, decide surgical technology, surgical timing, medicine, and devices. Thank you very much for your attention.
Thank you very much for that presentation. Now for the open for discussion. Hopefully, okay.
I'm Tetsuya Kuhara from the University of Yamanashi. Thank you for a nice presentation. I have a question. With radar technique, we can investigate the unstable plaque in detail. The depth of unstable contents such as lipids, necrosis and bleed, near surface, or the deep in plaque can be important factor, I think. What do you think about?
I think so. The most important thing about making imaging, plaque imaging contrast, I think. but conventional system, conventional image, difficult to different contrast inside the plaque, but later can get contrast imaging. Yes, it's important thing.
Thank you. Other question? Okay.
Thank you for your presentation. How do you differentiate the lipid plug and the breathing plug by later method? I didn't understand. Please tell me.
Breathing rate. Rate. I'm sorry, I'm not sure, but we are analyzing it now at this factor and the factor and the other algorithm. Great.
Thank you very much.
Thank you.
Okay. Thank you very much. Let's move on to the next paper. Let me introduce next speaker, Carrie Naomi Takahashi. Her will present arterial vein labeling to assess a pre and post-cerebral blood flow in Fukushima dilated bypass in Hawaii Moemedi patient. Okay. Okay. Could you start your presentation?
Aloha, welcome to Hawaii. My name is Callie, and I'm a second-year medical student at Georgetown. So, how did I learn about Moe disease? I was shadowing my mentor, Dr. Wong, and I would see young women, a few years older than myself, coming in with stroke symptoms, TIAs, headaches, and it really caught my attention because sometimes these women were just a few years older than myself, and I was able to learn about Moe from Dr. Wong and Dr. Holmes. Thank you to Lori and Dr. Fukushima for allowing me to come to present today. And in Hawaii, we show our appreciation with flower lace. So there are many people who contributed to this presentation, and I would like to thank them. So I know I'm speaking to expert neurosurgeons, and I was just wondering, does anybody use ASL to evaluate their Moe patients currently? Raise your hands. No. Okay. So a literature review showed only 2 articles in the American literature about ASL use in Moe patients. This one from 2011 and another one in 2017. So a little bit about what it is. It's a MRI technology that allows us to measure tissue perfusion in a non-invasive and without contrast. And Dr. Holmes will be doing a deeper dive into ASL in a subsequent presentation, so he'll go into more detail with that. But I will be doing a case series, so we have 8 cases, 7 of which are female, 1 male. The average age of presentation at the neurologist's office was 41.5 years. The current age of our patients average is now 46. Our data was collected between 2012 up to now. All cases are from Hawaii, and all patients were operated by Dr. Fukushima. So this is our patients. As you can see, so JC and AT, they're actually the same patient, but we decided to break them into 2 cases because they had both right and left encephaloduro-arterial biosyngiosis procedures. So in order to more clearly show the pre and post imaging, we decided to break it into 2. And most of our patients are Japanese. We do have a couple from Filipino ethnicity. And the patient on the bottom, ET, this is the woman that initially drew my attention to Moe because she is on the younger side. So I will be presenting the case specifically of Casey. She presented to the neurologist's office as a 39-year-old right-handed female. Her chief complaint was a transient left facial and upper extremity weakness, tingling for a few minutes with headaches. She was evaluated for Moe disease, And she had her first operation for the right side in 2013 and subsequently on the left in 2017. And she was most recently seen by her neurologist a few weeks ago and is doing very well. She had no surgical complications, no TIAs or recurrent strokes. Due to the time limitations, I'm just going to show the imaging from her second surgery. So the MRA pre-surgery shows on the left there's a focal middle-lateral M1 high-grade stenosis within the middle cerebral artery, so here. And then the arterial blood flow exam demonstrates normal and symmetric cerebellar and chronically asymmetric blood flow. There's which is moderately reduced in the AC distributions bilaterally, and the MCA distribution over to the right side is becoming much improved at 2.5 seconds. The color scheme for ASL, so this is our grade. So the red is indicative of better flow, where the blue is not. So this is the left side pre-surgery. Okay, and then after surgery, so the MRI post-surgery confirms patency of the bilateral dual-limb ECA to MCA bypass graft. Specifically, the new left-sided grafts are well seen. Both anterior cerebral arteries demonstrate flow enhancement, and they're fed by asymmetric and rather small A1 segments that are larger on the right. And there's probably also posterior cerebral artery collaterals. The ASL, it demonstrates significantly improved flow in the left middle cerebral artery distribution with persistent reduced flow in both anterior cerebral distributions. I know that I was talking about the color flow on the previous slide, and so ASL is meant to be seen as like a series of images, so it's just that this image that we chose didn't have it's just from a different slice compared to this last one. Okay, so all of JC and all of the Hawaii Fukushima patients have done well pre-op and post-op with no recurrent TIA or stroke symptoms. So this is a small number of patients that did well in this case series may suggest that ASL could be a useful clinical tool to non-invasively evaluate cerebral blood flow without the need for contrast. So what should we do with this data? Well, we're thinking about possibly doing a cooperative Japanese, Asian, Honolulu, USA Moe registry. This would allow us to compare data, surgical techniques, and see how ASL correlates with outcomes. So it would be similar to something like the Nihon-san study model, which was the Honolulu Heart Study, and we would want to potentially present this information at the American Stroke Association and the International Stroke Conference, which happens here 1 year from now in Hawaii. And then I know that I've only seen a few patients with Moe disease, but I know that everybody would be able to benefit from a registry if one were to be established. If there are any burning questions, I would be able to accommodate them now, but if not, my colleagues will be presenting, and after Dr. Holmes' presentation, we can have a discussion.
Okay, thank you very much for your nice presentation. Now, for the discussion, is there any question or comment? No comment? No question? You show our usefulness of ASL for some finding, very good finding. But ASL have some limitation concerning on the quantification, especially a patient with occlusion or patient with intracranial occlusion. Tracer arrival time is delayed. So low flow is enhanced by such a phenomenon. So in Moe disease, usually intracranial vessel is not occurred. So probably it's image is semi-quantitatively good, but in a patient with occlusion, you care
imaging intervention is very careful. Is there a question or comment?
Well, it's actually a comment on that. Actually, Dr. Holmes is going to talk about the various sequences that they use. So they'll use a 1.5 and 2.5 second delay sequence. Although at Stanford, they use a 4-second sequence. So, but I think Dr. Holmes will probably answer this question a lot better.
Okay, thank you very much. Any question or comment? Okay, thank you very much.
And next speaker is Dr. Margaret Krakura. His presentation is surgical revascularization treatment and arterial spin labeling in Hawaii Moyamoya disease patient. Please start the presentation.
Hi, my name is Margaret Crackler, like they said, but I'm not a doctor. I'm also a second-year medical student at Georgetown University with Cali. Today I will be talking about ASL use for post-op long-term follow-up in Hawaii Moyamoya disease patients. So I also would like to thank all of the doctors and people who helped contribute to this presentation. I value all of your input and your contributions. So, like Callie mentioned, the current literature on ASL use in Moyamoya disease is very minimal and still growing. Dr. Gary Steinberg at Stanford University has put out these articles. He found that ASL use is comparable to the gold standard of DSA imaging in identifying collateral perfusion in Moyamoya patients. That's the 2011 article. And in the 2017 article, he found that specifically long delay ASL use provides the most accurate and effective cerebral blood flow measurements in Moyamoya patients comparable to PET imaging. However, this is still currently the only literature out there, so more research is needed on ASL use in Moyamoya disease. So I will be presenting specifically on Dr. Fukushima's post-surgery cohort. These cases were Moyamoya disease patients who had surgery as early as 2001, and this was before ASL was available. ASL is now being collected on all of these patients, but it's only post-surgical data. ASL is being used to evaluate their cerebral blood flow after their revascularization surgeries by Dr. Fukushima. Currently, all 10 cases are neurologically stable and they have had no stroke recurrence since their surgeries. The average follow-up for these patients is 12 years with the maximum follow-up of 17 years, and they have all remained neurologically stable since their surgery with no need for recurrent surgery. So these are all of the cases. As you can see, their surgery dates were before ASL was available, so we are only using it to collect their post-surgical data. I will be presenting on DT. He is in 2004, he presented as a 55-year-old Japanese right-handed male. The only relevant family history he had was a daughter who was also diagnosed with Moyamoya disease, but this was after his initial visit. His chief complaint in 2004 was acute left hemiparesis, dysarthria, and ataxia, and he was found to have an acute subcortical periventricular infarction, approximately 2 centimeters maximum diameter, with a severe stenosis in the right M1. So the patient had a symptomatic right M1 MCA stenosis and was confirmed to have Moyamoya disease. Dr. Fukushima performed a right direct bypass, ECIC, in August 2005, and DT remained stable post-op. After his surgery, the only symptoms he exhibited were mild headaches with no numbness or weakness seen. Currently, he's being followed regularly with MRI, MRA, and ASL,
and he continues to be neurologically stable. He has not had any stroke symptoms since his surgery in 2005. So this is his ASL imaging from his recent follow-up in 2017. The first image on the left is after a 1.5-second delay, and as you can see, there is reduced flow in the posterior MCA region, which is consistent with his initial infarction. However, by the 2.5-second delay image on the right, you can see that the blood flow has been restored, and he has symmetric, stable blood flow to both hemispheres. So the 1.5-second delay image is used to evaluate early blood flow in the brain and identify any potential vascular pathology such as stenosis, while the 2.5-second delay image is often used to evaluate collateral perfusion that is characteristic with Moyamoya disease patients. It can also be used to evaluate cerebral autoregulation functioning because as collateral vessels form, there's increased perfusion through them to account for the ischemic area, and this is usually seen in the 2.5-second delay image. And recent research has associated focal hypoperfusion due to possible impairment in the cerebral autoregulation functioning with neurological deficits that have been seen post-surgery within 3 days. However, this is more of an immediate adverse event, so ASL would need to be done immediately after the surgery, and these patients, including DT, were not able to have this imaging done. So ASL could have the potential to look further into that association between impaired cerebral autoregulation and these neurological deficits often seen. So to conclude, the entire post-surgical cohort remains neurologically stable. They have not had any recurrent stroke or need for surgery, and they continue to be followed up by their neurologists with ASL imaging and MRI imaging. ASL has been correlated with good post-surgical neurologic outcomes, and it's an excellent and effective way of non-invasively assessing cerebral blood flow in these patients. It has accounted for better monitoring of symptoms of Moyamoya disease patients as well. I would also like to reiterate Callie's call for a cooperative Moyamoya registry similar to the Nihon-san and Honolulu Heart Study so that we can compare cross-cultural differences in surgical techniques, outcomes, ASL data, etc. to guide better practice for Moyamoya patients. So Dr. Holmes will be following me with his presentation on ASL, but if there are any specific questions for me, I would be glad to take them. Thank you.
Thank you very much. Is there any comment or question? I have a question. Can you know the difference between direct and indirect the efficacy of direct and indirect bypass surgery by ASL?
I'll let you decide after I present. That's too complicated for you.
Yeah, sorry. Unfortunately, I'm still learning about the subject, so Dr. Holmes will take that question. Thank you.
Thank you very much. Thank you, excellent presentation. We'll move to the next paper.
And don't forget, those are second-year medical students. I don't think I could have presented anything as a second-year medical student in a group like this, so good for them.
The next paper is presented by Dr. Holmes. The title is The Value of MRI Alters in Labeling Blood Flow for the Neurosurgeon. Pre- and post-operative monomer and tumor characterization. Please start your presentation.
Thank you. So can I give two pieces of information today. One is that neuroradiology can indeed be fun for everybody, and the second piece is about arterial spin label blood flow exam. So, I don't know what's going on. These images are going to come up just in just a second. Take a close look at them and understand that this is a young lady who presented with just headaches. And so her initial MRI, you look at it and decide if there's anything abnormal, and you'll see the value of providing a single ASL exam to make a diagnosis. We'll try it again. Anyway, let me tell you a bit about ASL. Arterial spin label blood flow is a technique using MRI without contrast to label blood as it flows into the brain. And as it flows through, we can get quantitative data concerning the amount of blood flow. And what's cool about it is quantitative, but it's relatively quantitative based on the time delay. That's why it's so important to understand this difference between a 1.5 second, a 2.5 second, and a 4-second acquisition. So I'll get into this. So it's different from gadolinium blood flow. Gadolinium is an exogenous agent, and it's extremely sensitive. As far as I'm concerned, it's too sensitive to accurately evaluate flow. So I think ASL is even better than gadolinium. And that's going to be one of my points when I show you these slides. Each sequence takes about between 2 and 3 minutes. So, and Einstein was actually discovered that time is money. And so every time you add a sequence to MRI, it's costing somebody some money. So right now, doing ASL takes between 2 and 6 minutes, depending on how you do it. So one of the impetuses for the industry is to actually provide a multi-delay sequence that you can acquire in a short period of time. And right now, I use ASL primarily. For Dr. Mel Wong, we do multiple delay times because he takes care of a lot of patients with stroke neurology. He takes care of a lot of patients with strokes, and he needs that information. But I use it on every single patient as a screening tool to define is there a stenosis. We've picked up tumors with it. And part of the talk, the abstracts that I'm going to describe to you what it can do for tumors, but this is, I can't do that, there's not enough time, but for a neurosurgeon, it's an amazing data set for tumors, trust me. So let's see if we can get going now. I've had fun so far, I hope you've had. So, take a look at this. It looks like a pretty normal scan. 37-year-old lady just comes in with headaches. And, that's me, by the way. So I'm at the Wide Advanced Imaging Institute in Honolulu. We have 3 Tesla MRIs, private practice, so I can do anything I want to. I can do ASLs in every single patient. I couldn't do that at the hospital. I'm going to go through this schedule here. I'm going to tell you how it's acquired, the value in disease detection. I'm going to show you flow patterns, and I'm going to emphasize this time delay. I'm going to talk about a little about symptoms. Post-flow evaluation, and then give you a conclusion. So, what it is, again, is blood flowing into the brain. This is upside down. It's tagged. And then as it goes through the brain, there's an early sequence and a second sequence, a subtraction, and we get an image that looks kind of like that. It's low signal to noise, so it's not very detailed, but it's got a lot of information. This is what it looks like. So, and you can see nice gray-white differentiation. You can see basal ganglia. You can see thalamus. You can see nice flow. And note the difference in these two here. There's better signal to noise the earlier you get it. That's at 1.5 seconds. So it's tagged. The 1.5 second is a delay, okay, as it flows into the brain. So you can image at 1.5 seconds. You can image at 2.5 seconds. You can image at 4 seconds. But there are limitations in every single one of these. And Rorschach, okay? And the key to all this is symmetry when you're analyzing it. So you're looking for symmetry. So basically, anytime you look at these images, that's what you're looking for. Asymmetric here. You can see this. This is the 1.5 to 2.5. Here's a patient with several prior strokes. You can see it's asymmetric. It's down on that side. It's quantitative, which is great. This is 100 cc. This is cc's per 100 grams per minute. So at 1.5, you measure it here. It's 59 cc's per 100 grams per minute. But at 2.5, it's 68. So even though it's quantitative, it's all relative depending on the time that you acquire the data. But it's reliable and it's reproducible in terms of that quantification. So most of the cases I'm going to show you, it's just the red and the green because you're talking cortical flow versus white matter flow. But other things can give you very high flow, and especially in tumors, and I find it very valuable. Take a look at this scan. Anybody see anything? And there's going to be a test question at the end, so pay attention. See anything? All right. Let me throw in a 1.5 second ASL. Nice depiction of this meningioma. It's got very high blood flow. Now, of course, you see it on the regular MR, but isn't that nice that tells you the blood flow of that meningioma, which can be very variable, by the way. Some meningiomas are low blood flow, some are very high blood flow. And so it doesn't really depend on the histology or the grading. Disease detection. This is what I use it for primarily. And I'm going to talk about slow is better later. So, same patient we talked about earlier on, kind of a normal non-contrast MRI. So we throw in an ASL exam. Now we see there's the Rorschach. It's asymmetric. There's less green on the right side. See that? So what's the next step? Well, you analyze it, you take a look, you say the brain's normal, but there's less flow on this right side. Let's recommend an MRA, even though she's only 37 years old and all she's got is headaches. We do the MRA, and she's got a high-grade right M1 stenosis, predicted by this ASL, but really hard to see on the regular MRI. This flow patterns at different time rates and versus a relative cerebral blood flow is an important concept as well. So I'm going to hammer this because it's important to understand the differences in these delays. And I'm going to show you this slide again in 2 more slides, but I'm going to show you several patients and the value of the different time frame. Here's a patient, 50 years old. I don't even know the symptoms. They were pretty non-specific. You can see he's got some areas, some T2 lesions in the right hemisphere. This is his blood flow at 2.5 seconds. The Rorschach test tells you it's symmetric. This 2.5 seconds is what a lot of people are using, okay? It gives you some information. What about if we throw in a 1.5 second ASL? Same patient. Now, you see the blood flows down in that right hemisphere? Oh, no, I'm sorry, it's a different patient. I'm going to go back to that one in just a second. This is the patient I showed you earlier, the 37-year-old. Blood flows down that right hemisphere at 1.5. It's better at 2.5, but there's still some delay back there, right? So, another patient, 77 years old. He's got a high-grade M2 stenosis. At 1.5, he's got a delay in his posterior M2 circulation. At 2.5, he's got good collateral flow. What does that mean for this guy? So now let me go back to this other patient here. So this is the patient I told you about that at 2.5 seconds had symmetric flow on both sides. At 1.5 seconds, there's very slow flow in that right hemisphere. So the next step is to get an MRA. And he's got moya, his right middle cerebral artery is not even there. So the value of that 1.5 second sequence. So the literature review that they've gone over, they concluded that ASL can predict the presence and intensity of collaterals in moya disease. And they also say it needs to be correlated with patients with routine ischemic disease. Okay, and I understand all this, but I'm going to talk about my philosophical concern about this at the end. Now, the difference between arterial spin-labeled blood flow and gadolinium DSC blood flow, it's basic. ASL, you use an endogenous agent, you're tagging blood, that's it. Now, you can get different time delays, and it's quantitative. Gadolinium perfusion, you can also get blood flow, but it's relative. It's not quantifiable, and as far as I'm concerned, it's too sensitive. Let me show you an example. Patient with moya who had a prior bypass. You can see the bypass there, some small strokes there. So his gadolinium blood flow looks very similar to the 2.5 second blood flow. That's been my experience. But the 1.5 allows you to say, hey, that area here has got issues, but he's got collateral flow. A little bit different though, not as good on this as this, and I think this is actually more accurate at that 2.5 second. One of my concerns is that we really have no idea what this means in terms of the patient's symptoms or follow-up. And that's one of my big criticisms of all this. We have no earthly idea. No one's really tried to correlate this with symptoms. And now that they know when you're getting a 4-second delay, that even throws some more mud into the water. Let me show you some surgical cases. After surgery, you can have 3 patterns. You can get no change, you can get improvement, and you can get new information. Okay, and it's an easy sequence to use, so it's easy to add it to every single case. So we go back to this original patient again, who just presented with headaches. All right. Now, here's her M1 stenosis. Here she is pre-op. Here she is post-op. So flow is down that right hemisphere at 1.5 seconds. It improves at 2.5 seconds. So she's got some collateral flow, but it's not perfect. You see how it's still down in the posterior division? After the surgical procedure, the anastomosis, the 1.5 second doesn't change, and that's because it's too slow. And that goes back to the question the moderator asked earlier. Slow flow will not show up at 1.5 seconds because it's slow. It hasn't gotten there yet. At 2.5 seconds, you have better collateral flow filling that because of the surgical procedure. Oh, yeah, there you go. Put the arrows to make it, make it better. So, in this patient, she had a normal brain MRI. You throw in a 2-minute sequence. The sequence says, hey, there's abnormal blood flow. Get the MRA. You got moya. You post-op, you get improved collateral flow. But what does that mean? And that's where, again, we don't know. We don't know what all that means. It can detect it, but in terms of symptoms later, we don't know. How about new information? Here's a patient who's got 25 years old, and she's, pardon me, that's my office. I got to go to work after this, so sorry about that. Here's a patient with a tight M1 stenosis, and here she is preoperatively at 2:15. Okay, so the blood flows down the right hemisphere, and this is at 1.5 seconds. Okay, after surgery, better flow, right? See that? But look, see she had nice flow in the anterior cerebral artery distributions here, and now the flow in the anterior cerebral arteries is low after surgery. Well, let's get another MRA, and for whatever reason is going on here, her anterior cerebral arteries are becoming atretic. The flow is diminished in that. So it gives you, this is new information in a post-operative patient. How many times I got to say this? It's important to understand this delay concept, okay? And the other literature that was presented, multi-delay ASL is important because the standard delay of this is 2 seconds underestimates reserve flow by up to 20%. I understand that. So what we need is multi-delay sequences where you run it one time, you get a 1.5, you get a 2.5, you get a 3.5, and that's how you're really going to analyze flow. But there are limitations, and the limitations is if they're doing 4-second ASL at Stanford, I can't do it because my system only allows me to go up to 2.5 seconds. In addition, the relaxation of blood is 1.5 seconds. However, when you tag it, you're not tagging all the blood, so it takes a period of time to tag all the blood. So that's how you're able to get data 3 seconds and 4 seconds later. Because the tagging is not instant, you're tagging over several seconds. But again, what's the value of knowing this perfusion? That's where we don't really understand. And let me show you a point here. This is a patient, a 48-year-old female we had recently that had recurrent episodes of aphasia. Now, she's got a pretty standard, here she is occluded here, maybe a dissection, who knows, internal carotid. She's got nice flow to the left side, even though she has occluded. She's got a PCA and ACA.
Dr. Holmes, please go to conclude.
Yeah, okay. I am. This is it. So here she is at 2.5 seconds. It's got a nice flow. At 1.5 seconds, it's down. She still had a stroke, even though she had good collateral flow. So we know it can detect disease. We know that slow is better, like in moya-moya. This is different from arthromatous disease, but that literature said, got to compare it to arthromatous disease. We know it's important. We don't understand the differences between arthromatous disease and moya-moya because it's a different pathologic process, and slow is really better. So, in conclusion, took you through how to do it, disease detection, the difference between 1.5 and 2.5. We really don't understand symptoms relative to this collateral flow, but it's an easy method of analyzing flow in patients with moya-moya, and it's the beginning of our understanding of all this. And so in years to come, it's going to be part of your practice every day. Thank you.
Thank you very much, Dr. Holmes, for your excellent presentation, but now time is limited, so thank you again. We'll move to the next paper from Dr. Takatsugu Abe, Department of Neurosurgery, Tohoku University. Title of his presentation is Efficacy of Intravenous Administration of Human-Derived New Cell Preparation for the treatment of brachial infarction in mouse. Please start your presentation.
Yes, thank you. Yesterday, Professor Kimura presented an abstract of new cells, preclinical, clinical, and clinical side. I will be giving a talk on the treatment of immune cell preparation for brachial infarction in mice. The immune cell is a novel type of endogenous stem cell. The feature of this cell are self-renewal, pluripotency, and tolerance for stresses. Immune cell can differentiate into 3 giant layers: ectoderm, mesoderm, and endoderm. The immune cells are other stem cells residing in mesenchymal tissues, bone marrow, adipose tissues, and TMS. And immune cells are sortable using the pluripotent surface marker SSES3. As for sorter, we use MAX or FAX. As previously reported, intravenously injected immune cells migrate to and integrated into damaged site in injury models of organs. And these differentiated into functional cells. And in our previous study, we assessed the efficacy of immune cells transplanted by local injection. We subjected skid mice to brachial infarction and administered immune cells to infarction core. And these pictures show immunofluorescence 8 weeks after immune cell administration and behavior test. And these results indicate the efficacy of immune cells local transplantation. So from here, I talk about this experiment. In order to assess efficacy of human-derived immune cell preparation as a preclinical study, we use brachial infarction model. Immune cell preparations were provided by Life Science Inc. We administered immune cells intravenously 9 days after infarction. animals skip mice, we conducted stereotaxic injection of MC1 and LNAP to write internal capsule. These pictures show operative blue and look sulfur staining. Red slag indicates infection site. The immune cells or vehicle were intravenously administered via gyral vein. Cell count of immune cells is 50,000. As for assessment to detect engrafted cells, we conducted immunofluorescence of human-specific mitochondria and PCR of human-specific DNA. To assess upper extremity paralysis, we conducted cylinder tests as shown in top right screen. As for loss of function tests, using tetrodotoxin, we selectively eliminated immune cells. This diagram shows scheme of this experiment. Immune cell administration was conducted day 0. A rapid infection was 9 days before. The endpoint was 10 weeks after. The bottom picture shows immunofluorescence of human mitochondria. The positive cells were observed in the peri-infected area 1 day, 1 week, and 10 weeks after immune cell administration. This graph shows result of PCR of R sequence. R sequence is repetitive elements in the human genome. The human DNA was significantly high in the right brain. This picture shows immunofluorescence of neural markers MAP2 and NOEN with human mitochondria. The upper plan shows NOEN and lower shows MAP2. In each staining, triple positive cells were observed in the interrupted pyramidal tract. On the other hand, GFAP and GST-Pi signals were not correlated with human mitochondria positive ones. This line chart shows time course change on cylinder test after administration. Each number is 14. Significant differences between two groups were observed at 8 weeks and after. The left line chart shows time course changes on cylinder test after administration, including post-tetrodotoxin administration. The right chart shows changes on cylinder test before and after tetrodotoxin administration in mouse group. To sum up, grafted immune cells were detected at 1 day, 1 week, and 10 weeks, and differentiated to neural cells. In cylinder tests, recovery from deficit was observed until 10 weeks after cell administration. We can detect immune cells administered intravenously. Then I take a question: how immune cells can migrate to injured organ? In the recent report, acute myocardial infarction patients presented high concentration of S1P, and immune cells express S1P receptor. And they describe that S1P may attract immune cells to injured organ. In conclusion, this immune cell preparation was used as a preclinical study. It produced the recovery from neural deficit in rapid infarction mice models, and immune cells engrafted in interrupted pyramidal tract. Thank you.
Thank you very much. Is there any question, comment?
Yes, giving you a chance to ask questions on the previous presentation. I wanted to emphasize that the ASL presentation is based on 120 cases altogether, 120 patients who have been bypassed by Dr. Fukushima. Not a few cases represented on the slide. 120 patients.
Thank you very much. So, thank you very much. Now we close this symposium. Thank you very much.
Thank you for the cooperation for all the participants. Now the session is closed. Again, the basketball golf tournament starts at 10 a.m. So I'm sorry for very limited time, but please gather at the lobby as you can. Thank you very much.